Welcome everybody to the HCMA Facebook page. Today we're going to be acknowledging the program down at University of Pennsylvania, which has just become an HCMA recognized Center of Excellence. And before we meet with the team, I am going to explain a little bit about what a Center of Excellence is and where you can find more information out about what it means, how to become one, and how to get to one for your care of hypertrophic cardiomyopathy. So first of all, you can always go to the hypertrophic cardiomyopathy website at 4hcm.org to look up the guidelines about Centers of Excellence. A Center of Excellence is more than a physician who cares for patients with hypertrophic cardiomyopathy. It is a comprehensive system of expert physicians who have expertise in the field of hypertrophic cardiomyopathy. So you'll have non-invasive cardiologists, invasive cardiologists, transplant specialists, electrophysiologists, imaging professionals, genetics professionals, and surgeons. And we put that all together in a comprehensive team approach that provides the best quality of care for patients with hypertrophic cardiomyopathy. A full list can be found in our directory online. And just this past month, we have identified 5 new programs that we are launching this month. And the first of the programs is University of Pennsylvania. And now I invite Dr. Owens to join us here at the HCMA website, Facebook page, to tell us a little bit more about the program. Dr. Owens, welcome.
Thank you. Thank you. It's good to see you, Lisa.
Good to see you too. So why don't you tell us a little bit about how the University of Pennsylvania took a genetic cardiovascular program and twisted it around a little bit to specialize in hypertrophic cardiomyopathy.
Happy to do so. So it all started really when I was a fellow here, and I finished my fellowship in general cardiology and then went on to do an advanced fellowship in heart failure and transplant. And it was during that year, along with my mentor, Marielle Jessup, that we had the vision for starting a cardiogenetics program and really looking at inherited cardiomyopathies in general. And Dr. Jessup, who was a true visionary, sent me out to California because we did not have an inherited cardiomyopathy program here. And I went out and met with you and Ashley and his team and stayed there and learned from them for several weeks. And when I came back, we had the idea to go ahead and start the program. And so when I started on faculty, which has been probably 6 years now, it started as a general familial cardiomyopathy program in conjunction with our children's hospital. And over time, we saw that the vast majority of our patients had HCM. And so we felt that they deserved and needed a dedicated program, a dedicated clinic day. We have dedicated genetic counselors, and really a team of specialists that know HCM, care about HCM, and take care of whole families.
That's wonderful. I love that one of our other centers of excellence, Stanford, was your mentor of sorts to create the program.
Absolutely.
Yeah, they have a wonderful.
And he continues to be a mentor. He's absolutely wonderful, and we modeled the structure of our team off of his team.
Well, that's good. I'll actually be out there later next week again. So let's talk a little bit about, you talked a little bit about your background. Tell us about the rest of the team here.
Mm-hmm. So we have a team that, as you mentioned during the introduction, is multidisciplinary. We have a surgeon, Dr. Pavanat Luri, who went out and trained both with Hartzell Schaff and with Nick Spadira during his training for doing septal myectomy. And we have now started a surgical program that's been present for the last 2 to 3 years. So we're a growing program surgically. We have 2 interventional cardiologists, Dr. Howard Herman and John Hirschfeld, both of whom have been doing interventional cardiology for over 20 years. And they were some of the original providers doing alcohol septal ablation. So they are truly experts in that. And we have a local expertise in that regard. We have 2 genetic counselors that are full-time with our program. So they're there to meet the genetic counseling needs and testing needs for our population. And we have 2 dedicated nurses and 1 dedicated nurse practitioner. There's another partner of mine who sees patients. He also is heart failure transplant trained, Ken Margulies, and he sees patients in our clinic. And in addition, we have our host of imaging cardiologists, electrophysiologists, our partner at CHOP, Dr. Kimberly Lynn, that kind of round out our team.
So if a family were to come into your program and they have teenage children, maybe 13, 14 years old, and maybe adult children, 20, 22, and moms maybe 50, how would they go about being seen? Would they be able to come in one day, or is it multiple visits?
Yeah, ideally, our goal is to be able to provide family-based care on the same day with a specific agenda for each family member. So our program director, Eric Smith, and our administrative assistant, Melissa Haraday, tried to take an intake, a triage when the first patient calls in, so that we understand the needs of the whole family, and then we can plan accordingly. So any adult, which is basically age 17 to 18 and above, we can see here at the Perlman Center, which is in Philadelphia. And then right across the street is our children's hospital, CHOP. And if there are very young children that the parents, really need to be involved and it's a few hours at CHOP, then we can do 2 separate days so that the children can be seen one day, the adults on the next day. Screening visits for patients who are not known to be affected with HCM but need a screening evaluation are seen generally by our nurse practitioner, Amy Marzoff, and she's absolutely wonderful. She'll see them, we'll have the echo done on the same day and the office visit. And then any patient who's known to have HCM or highly suspected will be seen by myself.
Wonderful. So it's a big program down there. I was impressed with the campus and the structure and the proximity to the children's hospital. Is it easy for patients to navigate, to find their way around, and to get everything done?
I'll be honest with you, not always. They are working on better signs. If you'll remember when you were here, they were actually putting up the new signs. So they are really working on signage and having people available to direct patients. Because as you mentioned, it can be overwhelming. And driving to Philadelphia sometimes can be overwhelming. So we do our best to have parking available, an easy place to grab a coffee or something to eat, and then better signs in our clinic. We do have a heart and vascular center. And so that means that you can get your echocardiogram, your stress echo, your Holter monitor, all on the ground floor, and then come up to 2 East Perlman, which is where we have our clinic. And once you enter the clinic area, you can be seen by our clinic, you can be seen by electrophysiology, you can be seen by cardiac surgery, all in that same module, that same area. So that helps.
That's great. So I know we're working on another project together with cardiovascular care models, genetics care models, I should say. But are there any particular areas of research interest that you have at this time or your center?
Absolutely. We have a number of areas of research and also of innovation in care. And I would say that those are the 2 things that may help to distinguish our center. One is that we have a very large transplant program, as you know, a heart transplant program. And so one area of interest for us is identifying patients sort of early on that are headed towards transplant so that they can be evaluated at the proper time before organ systems have irreparable damage, if you will. So that's a particular population that's of great interest to myself. The other thing that we have is a telemedicine program that we're piloting. And that will allow patients to have genetic counseling and sometimes even testing without having to travel to Philadelphia. And we think that that will be a major asset to the program and to other programs in the country, the more that we move towards telemedicine. The third area of interest that I would say is a big one is one that we embarked upon with my partner, Dr. Kiran Musunuru. He is an expert in genome editing. So looking at the DNA or the blueprint of the body, identifying changes in the DNA that may lead to hypertrophic cardiomyopathy and being able to repair or put back the normal sequence of DNA and see what happens. So we have a growing program using induced pluripotent stem cells or iPSCs. And surprisingly and amazingly, you can make these cells simply by drawing a couple of tubes of blood. So we have a research program where if patients or their family members want to participate, they can give us their blood, enter the research protocol, and we can make beating heart cells from those blood cells and then do tests on the genetics and the functioning of those cells. And that's one area of research that we think will be very promising in the future. Not ready for prime time yet in terms of bringing it back to the patient, but certainly in the research realm, we're making great strides there. And Kiran is leading the charge.
That is, we've been listening a lot on the news to the CRISPR-Cas9 data, and it got the attention of popular media. In fact, 60 Minutes had contacted me about doing a program on it. I'm not sure
Oh,
if
wow.
I'm do with it or not.
Yeah, not easy to just talk generally about CRISPR-Cas9.
No, it's really complex stuff, but it is really exciting that
Absolutely.
even the realm of possibility is there that this might work at some point to bring into human studies. So I'm hedging my bet here on the questions that are going to come up after that. Where do I sign up to have that done? So remember, bench science right now, people, and slowly.
That's right. The clinical research studies that we are involved in that are ready for clinical research are the myocardia studies. So we were involved with the first in human phase 1 study, the next phase 2 study, and we will be involved with the phase 3 studies. So those should be coming online 2018, probably here in the first or second quarter. So we will be actively recruiting for both patients with obstructive and non-obstructive HCM who are interested in participating.
That's fantastic. I'll be meeting with them next week to discuss how we're going to be helping them with the recruitment aspect, hopefully.
Wonderful.
So we'll get that done. Let's talk a little bit more about that telemedicine issue. Yeah. So if somebody were in your area, but they have a family member in Iowa, mm-hmm. How would that work? You can just Skype them, or what happens?
So there are some licensing issues that have to be taken into account. So the way that we're piloting the telemedicine program currently is with another sister hospital in Pennsylvania, Lancaster General. And what we have is a contract with them so that our genetic counselors can provide genetic counseling and testing services via a medical Skype, if you will. It's a HIPAA compliant Skype. And we have hour-long appointments set up, usually on Mondays in the morning, and our genetic counselor will spend time talking with patients and actually their families. We can do group visits. Again, they last about an hour, and we go through the typical genetic counseling process. We'll draw a pedigree, take the full family history, talk to them about the genetic testing that's appropriate, and if they're interested, we will go ahead and sign a consent by having a nurse or another partner on the other end with our sister hospital, and they'll draw the blood, sign the consent. We direct where that blood is sent by helping to determine which company we're going to use for genetic testing. And then we receive the results, and we have a follow-up call, typically when the results come back 6 or 8 weeks later, to disclose the results and let the family members know what is the next step. You should have screening, you're okay, you don't need screening, and we go through that whole process. So currently, it is done with a sister hospital in Pennsylvania for licensing issues. There are larger telemedicine programs where you can get licensed in multiple states and then be able to kind of cross state lines, if you will.
So right now, we're holding your program into Pennsylvania state lines only.
That's correct. That's correct. And we have a contract with the hospital. So, we contract on a certain number of visits that we can do, what the charge is. We are not involving medical insurance at this time. So it's kind of a fee for service, but it's covered by the hospital, not by the patient. And so that part is important. And the hospitals are happy with the service so far that we've seen. Our oncology service is ahead of us in this, and they now have contracts with several hospitals. And the hospitals are quite pleased with the service.
Yeah, that sounds exciting and makes it more accessible to more people, especially in rural areas.
That's exactly right. And that's what we're aiming to do for HCM population, is to expand the access, get people into care, let them understand that they need to be tested. We're all about that. Love
it. Because if we get more genetic testing done, we can identify more people earlier and maybe get in there and change the story a little bit. Absolutely. So now the challenging question.
Yes, I'm ready.
I know. Now we get tricky. So we know HCM is multifaceted. What do you personally think is the most challenging aspect of identifying or managing hypertrophic cardiomyopathy?
It's a great question. I think it varies depending on whether you have a person who predominantly has pump failure, obstruction, arrhythmia, or diastolic heart failure. And I'll tell you that the most challenging population for me are the people with severe diastolic heart failure, or heart failure with a normal ejection fraction, where we really just can't get that heart to relax, and we're starting to see it change. It's getting stiffer and stiffer. The top chamber of the heart, the atria, are getting bigger and bigger, and we know that patient is going into advanced heart failure. I find that population of patients the hardest to treat, because it's very difficult to make them feel better. And it's hard to know when to transition to transplant, quite honestly. And so I find that group of patients the hardest to treat.
It is a challenging bunch. I was that challenging bunch. It's always nice to make your doctors a little white-knuckled as they get into the process.
Right. That's right. And I should add, the other group of patients that make us a bit white-knuckled, Amy, my nurse practitioner, and myself, are the growing number of patients who are pregnant with HCM. And so we have a crew of patients, some of whom are post-myectomy, some of whom are not, who are pregnant. And so Amy sees them once a week, very closely with our maternal fetal medicine group. And knock on wood, we've had very good success with getting people through safely, and all of those children born safely. But I will say that's another group that give Amy and I palpitations.
Please don't get palpitations. They're no fun. We've had enough for all of you. We actually are working on a program that you and I should talk about later, about creating a document for managing HCM during pregnancy.
I'd be happy to be part of it.
We will tie you into that group, which I'm a little behind on right now, but I'll get there. Okay, so those are the challenges. You kind of touched on this before, but let's hit it again. What are your hopes for the future of HCM?
Pie in the sky, we would prevent HCM. We would identify at birth or near birth the people who are at risk by genotype, and we would then institute a therapy that would prevent any hypertrophy. Pie in the sky. Or corrected in utero. That would be ideal through genome editing. Do I think we're there or even close to being there? No. Quite frankly, we've got our work cut out for us, but I think that should remain the goal. And each and every time I see an adult patient who is contemplating having children, or a patient who has young children, I can see it in their eyes that is what they want, and that's what the community needs. And I think we should strive to do no less.
So we do have the opportunity to slightly do that with PGD. Mm-hmm. But it's labor intensive, and there's those, date nights that screw it all up for us.
That's right. And it's expensive. And, we have had some insurance battles, and we've won some, we've lost some. But when you're talking to a couple and they may only have 3 embryos and then 2 of them have a mutation, then it becomes difficult. It's challenging, because at the end of the day, they want a healthy baby, but they want a baby. And we have to face those realities as they come.
So I just dropped the term without explaining it to the audience who may not know it. Can you tell us a little bit about what PGD actually is?
Yeah, PreImplantation genetic diagnosis is a process that we use to see if an embryo, or an egg that's fertilized, has a genetic mutation that we're looking for, a genetic change that can cause HCM. So if you're a family that knows your genetic change and you know that it's disease causing, and again, that's a critical point, because you wouldn't want to make these decisions if you're not sure that the genetic change is the one that causes HCM. So you really want to be sure that this is the cause. And once you're sure, then you have the option to test the embryo before it's implanted using in vitro fertilization, and then select an embryo that doesn't carry the disease-causing genetic change. And by that way, you implant the embryo that does not have the genetic change, and you're assuring that you're not going to pass on HCM to your children.
We've had a couple of successful cases, and we've also had a couple of people who thought they were successful and found out after the baby was born that it didn't work. So it's still not 100% for those who are wondering. It's got about an 80% success rate, I think, at this point, depending upon which, system you use to identify the mutations. But it is an exciting option. And absolutely. I choose the word eradication of HCM. Like the hope is someday to eradicate it. We may not be able to cure it, but if we can stop it from ever starting, it might be as close as we come to that. So is there anything else about your center that we should know? Anything different about infrastructure or staffing? Any just random thoughts?
I would say that we're working on a few innovative projects. And the three things that I think are most important for a doctor who treats really anybody, but specifically HCM, is that you need to find a team that, number one, will listen to you. So if you find yourself in your office visit and your doctor is talking more than you are, then take a pause there and make sure they're listening to you and they hear what you're saying. Number two, you need a doctor who can explain things in plain English, because there's a lot of medical terminology that's thrown around. But if you leave your office visit and you don't quite understand where you are and where you're headed, again, I think that that's an issue. So having a cardiologist that can sit with you and take the time to draw the picture, to make sure you understand it, and if you don't understand it, to try another way. I think our team is excellent at that, if I may say so. We spend a lot of time. Our average new patient visit is about an hour and a half long. My nurse practitioner, Amy, is phenomenal at really making sure that everybody understands where we're at and where we're headed. And I think those things are critically important. And then you want somebody that's going to be innovative and that's going to look to the future and see what we can do. And we have a sports cardiology program that's starting in conjunction with a partner here that I think is good for young people and older people with HCM who want to exercise safely. I think that's one thing that will separate our program. And then, as I alluded to, a very large transplant program. So we can take care of patients from the beginning of HCM all the way to the point that you may need a VAD or a transplant.
So you brought up a couple things. I'm going to unpackage there a little bit for our viewers. So going back to looking at, I'll go last to first,
Okay.
the transplant issue. It's becoming a more important issue in HCM because I think we're better at managing it and we're better at getting people through those hurdles to get to transplant. But it's a scary proposition. Do you manage the patient with HCM all the way to transplant, or do you turn them over to the transplant team at a certain point?
No, we manage them all the way to transplant. So one of the benefits of my training is that I specialized and did an entire year in heart failure and transplant. So fully trained to take care of both pre and post-transplant patients, including immunosuppression, heart biopsies, et cetera. So we take care of our patients all the way through to transplant in our clinic. Once you're listed as a status 1B or higher, we have a specific transplant clinic where myself and 14 partners care for patients, and we take you all the way through. As you know, there are many times where we need an exception to be written in order to get patients with hypertrophic cardiomyopathy whose hearts don't look like the average heart with dilated cardiomyopathy safely to transplant. And so we are fully equipped and ready to do that.
So the good news there is UNOS is creating a guidelines document that should be open for public review shortly that lists better criteria for listing patients with HCM. So hopefully won't be as many hurdles for you guys to jump through, and we here at the HCMA are helping UNOS with that particular project. So fingers crossed it'll make your lives a little bit easier so you don't have to waste so much time on administrative nonsense.
Absolutely.
Let's get to the point here. So going back into the innovative modeling that you have there and what your hopes are for the program, tell me a little bit about the institutional support that you've received from the powers that be at UPenn.
Happy to. So it started with my mentor, Mariel Jessup, who has been wonderful and instrumental really in shaping my career. She knew that this was a niche that we needed here at Penn that we didn't have, and so she helped me to develop it. And with the support of our current chief of cardiology, Dr. Tom Coppola, he has been very helpful in giving us support. So we went to our health system, we showed them, here are the number of patients that we care for that have these inherited conditions. HCM was one of them. And this is the group of people who need care in this area. And they were incredibly responsive. They provided us with genetic counselor support dedicated to our program, nursing and a nurse practitioner, a program manager, a research coordinator, and the support goes on and on. We go back to them periodically every 3 years or so and say, this is where we're at. We're in a cycle now. We are due to go back to our administration, and we'll be asking for additional support. So we have a full-time MD position open, and we are actively recruiting for a second physician to be full-time in our program. And along with that, I think we'll need another nurse practitioner. So we are growing by leaps and bounds, and I can say nothing but support has come from our administration.
That's wonderful. How many patients are in the program now?
Several hundred. I can't tell you exactly off the top of my head, but it's more than 500 and probably just shy of 1,000 in that range.
Okay. So that's a lot of hours spent with hypertrophic cardiomyopathy. So you learn something in all that time, don't you?
Absolutely. Each time I learn something.
Have you ever seen two that are exactly the same?
No, not even identical twins.
I know. Isn't that
a few pair?
That's crazy. So I'm going to take questions in a few minutes. And remember, we can't comment specifically on your individualized treatment. So we're not going to address specific medication issues or what's best for your HCM. We encourage you to speak to your own personal physician or get in touch with an HCM expert through our website. But I'm gonna leave a softball question here while I start to organize these questions here. So when you're not working, Dr. Owens, what do you do with your time?
Well, I somehow managed to have 3 children. So I have 5-year-old twins, and my baby is now 1 year old. So I am back from maternity leave full time. And when I'm not here, I am mom to the kiddos. And I have a wonderful husband who, thank God, can get home a little bit earlier to help out with the kids, and a very supportive family. So I spend time with them.
That's wonderful. And being a full-time doctor and a full-time mom, those are like 5 full-time jobs in itself.
Pretty much. We're going on vacation next week, so I'm excited about that. We're going to the beach and taking the whole family. So it should be a good time.
That's fun. Beaches are important. I think they should be covered by insurance. Can we work on that?
That's right.
So the way these questions work, they kind of pop in over us. So Robin had a very long comment here. She has a 2-year-old grandson who was tested when he was born, not genetically tested, but clinically tested. She has HCM. She's 56, and her daughter is diagnosed when she was 3 weeks old. She found out HCM at 17. I'm a little confused here. Oh, you found out at 17 you had the disease. You had open heart back at the NIH back in '82, so Dr. Morrow probably. Your daughter and I both have pacers and defibs. What can you do to get your grandson into the program? His 33-year-old son is borderline, and they live in Voorhees. So the easy answer there is use the link on the HCMA website, which will be there shortly, and contact Dr. Owens and her team and set up an appointment for a consult.
Yes.
That's an easy one.
And then the grandson seen at
Yeah. So I'm not so sure if the grandson was up here or not, but yeah, we can definitely get the family seen. Kristen is singing your praises. She's a patient of yours, and she loves you and your staff, and she's getting great care at UPenn. So an unsolicited.
Love you too. Cameron is doing well.
That's really good. So Robin has a question. Do these programs in Florida? Do you have these programs in Florida? My daughter is 22, has HCM, and does want children, and she lives in Florida. Can you recommend somebody? We don't have anything in the Daytona area, but we do have a program right now in Orlando, which is expanding in the coming year. And we also have a program in Weston, Florida, at Cleveland Clinic, which is on the brink of being formally recognized as a standalone. They've always been a satellite of Cleveland Clinic, Ohio, but they've brought in some new resources, and we're working on an independent program there. If anybody else has any questions or comments, we ended the broadcast. I don't know when we ended the broadcast.
It's one way to do it.
This is the second time this has happened to me. Or has it? No, maybe it hasn't. No, there's nobody here now. Oh, no, there are. I lied. We're here. We're okay. You can tell I'm not an audio visual professional. I split up the camera too much. I'm like, oh, wait, we lost everybody. No, that happened with Dr. Jeffries when Facebook went down. Sorry about that. Okay. Yeah. I was never meant to be a broadcaster, but I'm trying here on Facebook. Okay, so if anybody else has any other questions, we can address them now. I can tell you that this was a 1-year process, getting through the approval process and meeting with our boards and going through this entire endeavor that is a Center of Excellence evaluation. Yeah, thank you, Annie, I saw that. We'll just pretend I didn't do that. But going through the entire process, we get to meet a lot of wonderful people at the centers, and we found this to be a completely delightful program. And yes, you're in the middle of Philadelphia, but you do have some really interesting features here that some of the other programs don't have when it comes to traveling in. You've got a major airport nearby and a train station literally in walking distance. So anybody on the Northeast corridor can find their way into Philadelphia quite easily without having to navigate a lot of traffic. So I would encourage people who are looking for a fly-in program to evaluate their insurance and maybe consider this. As we know, we're at a bit of a lack of HCM programs in the Washington-Baltimore area, and it's a quick train ride right up the Amtrak line to get into a program at UPenn. So I would encourage you to consider it in your potential options for treatment. Okay, we don't seem to have any other questions. Annie, just, I'll put your little quote up there saying, no, you're still live. Thank you so much for letting me know that I made a jerk of myself. It's okay. Okay. Anything else you want to add, Dr. Owens?
Well, I just want to say thank you, that we are thrilled to be a part of the HCMA network. We think that the HCMA is a tremendous asset to the community and happy to partner with you going forward. So thanks.
Thank you. We look forward to a lot of great years ahead and a lot of people with HCM getting proper quality care. So thank you very much for everything. Thank the team at UPenn on our behalf, and we'll be talking to you soon.
All right. Take care.
Thanks.
Bye-bye.
And now we